Yeah.
Last spring, we proposed to the EPA to have it done that. So we applied for an CA 3 years, 6 months of 6 months of residency.
Just your
4 years. And 6 months and 6 months.
Okay.
It splits up that. I think it's 5 or 6 of the program.
OB we do.
Yeah, like just you had one.
Most places it's
So we have a 2 for extra over the summer.
here it's
2 interns.
between 2.4 and 2.6.
Are those 2 OPAs or is it now 20?
Nope.
I've been lucky.
Okay.
20.
So it would just be like
No, it's 16.
So it'd be as
and
in
then
the
3,
bus or
and then you 6 and 7. And here it's really nice because there's
So we'll see how it goes.
there's like 8 people until like 9 midnight, and then there's another 8 people on with you overnight, and so you alternate cases.
interesting because I
You don't have to
like
do
I mean my
there's one
experience
running the
with
whole night,
the critical
you
care
stay
program
up the
here is
whole
that
night.
it's not necessarily the most
So,
attractive
know.
of like setups.
Oh,
I don't know if
In
that's
Denver Health, you
like
there's only one room running.
I don't know.
You're always setups.
If there's only one room
Well,
running,
so
you
like
do all the cases.
I guess
Um,
from my experience in
and so
different
you're- you don't
institutions,
much
the
say there.
critical care program,
I
like
would say that
critical
those
care
are, like,
program
better
here is a little
cases
more.
tonight, though. There's a lot of like
I don't know. I mean, you know, the sticky and the CTIs
even
are
if
rough
you're like in
rotations
like
for
the
us
lab
here,
acting,
and they aren't necessarily that way everywhere.
Which is kind of cool.
So I don't know. It's just interesting
Here
because
it's
you
a
wouldn't
lot more
necessarily
common.
know that going in.
Yeah.
But yeah,
I think that the faculty that there's a couple of here just super happy with this stuff. And I think they want to know that. You know, most academic institutions like
But
the
out here, it's really not bad. You'll have
that's actually that it's better.
Yeah.
That's nice.
I had a shift with
Yeah.
cases, like a Sunday night or something.
Yeah.
I came in.
That's the idea. When they
Saturday and Sundays are nice because they have like the day
Yeah.
to get through all the like
Yeah.
sort of
Yeah. My brother
not
did
for emergencies
ICU
but kind of like urgent
fellowship,
cases.
and
And so
I mean
then
they have
as
some
long as
research
people
time
come
built
like
in,
Saturday
but
and Sunday,
yeah, he did crew medicine, not
it's really
anesthesia,
true.
but
A lot
still
of
it's like 18 months straight of just ICU the whole time.
You're just helping
Because that's so that's
really long.
Yeah, he did home care. Yeah.
that's 3 years for potential, right?
Yeah, 3 years. So I think he did, 18 to 20 months of clinical stuff, and then the remainder time was research and but still,
So it's
rough
the way it
story on
works is
all
like so
basically
yesterday I
every
was the
2 or 3 nights
resident,
for
so I worked like
a year and a
6
half or
days
2 years.
with that shift like
But
you
some people like it.
Get out at 7
I wouldn't do it
unless it's
myself.
like really
No.
awful. Maybe
Yeah.
6 like 7:38, but it's like really rare.
I mean, you have to talk to
Sometimes
Kenji.
if
Kenji wants
or
to
if
know.
you're really good, you'll get out like I've got out 5:30 sometimes. Even
I know.
though
He sent that out to the group chat. He was like, people were talking about their elective request for next year.
like today I
He was like,
came
oh
in
yeah,
so
I requested
slept this
Mickey
morning.
was supposed to be really competitive or something, and everybody just rolled their eyes at it.
Morning and then I was all day tomorrow. And then I just go back to a regular day shift on Thursday.
Yeah.
So it's
Funny because both Tim and Cindy, when you say, like I talked to both of them, and they're like, oh, I'm applying to critical care. And you go, oh, gross. And I go, yeah, I know.
not even
Like, well, why?
because like yesterday I didn't have to do any pre-hours.
You like
those two, but CT
I just like
transplant.
did my cases
Really?
and show up today.
Well, I'm glad there's someone doing that.
Really, it's gonna make sense.
Yeah.
You only got like 16 hours over the course of 2
What's that?
days.
Dan hadn't seen you in a while.
I know, it's been all.
Either 10 or 12-hour days.
Welcome back.
It's not. I don't know. I mean, it definitely can be
Okay.
hard doing the nights. And
Making it through.
Yeah, I think so.
How's it going, Glenn?
Yeah, but honestly, sometimes
So I've got a lot of research.
Nice. Looks like you're on a research.
you get excited to be off to the rain.
You ready to finish?
I was like so freaked out.
Nice thing is you don't get that
Staying
one
here
time.
for CT, right?
Right around this time of year last year.
That was E3
And
before we
it's
changed it to that one.
Yeah.
You
So I've been here this year.
Please
Yeah.
don't say APS, you don't want to see that.
You can be pretty miserable.
Okay.
I'm like,
They're
it's
good.
like 9
They're
days.
good.
I'm working so much.
Yeah.
So it's still like,
That was
you still
And
look
I think
hard.
our year
I
will
was
hopefully be
surprised
better
that
than even your guys
how
was.
tired I am.
It's been a whole lot better.
It's still
The second part we did blocks because
angry.
the
Yeah.
team format, you know,
Most of
the this works, it's just kind of the process.
Yeah, you're not like coming in line with all of that.
I think so. It's just motivation.
That was really hard for most pass.
Yeah.
And
You're trying to remember and there was
Yeah.
tons of stuff that is gonna be super.
Yeah.
We had a patient who got a
And that
bolus
really
of
does make
60
a difference.
cc's of epidural fluid the other day.
6-0.
the nurse misheard Robin say 6 to 60. Apparently did okay. Didn't end up in ICU.
That person's still alive.
Epidurals are amazingly forgiving.
How long does it take to put that in?
15 minutes. And that's the thing. There's a heart limit on your pump. So you have to go through 3 20 ml bullets.
Whoa.
Did you have
Hey, what's up?
What's up, Rob?
Luckily,
Yes.
luckily, it was probably in her, like paraspinal muscle.
I was gonna say, yeah.
Like they're factor bolusing, it probably means it wasn't in the right space.
I was gonna say after 60 she had no pain relief. It's like, all right, try 60 more.
Yeah.
What do you have left rest of the year?
That was
Got
Is it okay to
2
do that?
more
Am I gonna get picked on?
What's that? You're not cheap
there's
anymore. You're
like a
not.
clinical month.
Stick you.
I never did anyway.
And then I got anesthesia. I'm not sure.
We're never gonna review.
I know.
No, that's
So,
never happening.
it's
Never happening.
So it'll be like,
I was with him in a liver all day.
but hopefully close enough that I'll make sure everyone knows.
Yeah.
Is
Is it here?
I was on liver call yesterday.
Yeah, you do several cases.
I was in an MRI all day today.
I liked it.
Just more brutal, I think.
That.
I dropped my last patient off just now, and I look at her. So she had one IV impacted that fluid, and then they put another one in pre-op. So then they put another one in pre-op. That when we got back to the room, it just infiltrated.
I like
So then me and the MRI team were working on both arms. Like there are 20 gauges like right here. It's working great. Get to pack it with her arm is like this.
It would be nice to get to know.
And she goes, "Oh, this happens to me all the time."
Yeah.
And I was like,
Yeah.
I still feel bad.
It still sucks.
Yeah.
And really honestly, like, I think that on the anesthesia side,
I've had
I like
created a lot of the like
They probably
Like
might
doing
be worse.
trauma or something when it comes to
like, you have to write
Was that more
additional
nice?
hours
Most
of
nights,
CPR, like, I'm like,
Yeah.
doing it
there's
It's
like
terrible.
six, like, these
The
back
land.
I don't know how much I
Yeah. Yeah.
So
I got
there's
the
a
same
place
place
that
every
was
day.
for the anesthesia
Oh, really?
documentation,
Yeah, one got me out for
which like
Yeah,
is good
I did
stats,
for
and
lunch.
it's like you kind of like
Because on some ways,
yeah, but
I had a
once you're used to
lady
that, it's really
vomit in the scanner once while she was on her back. And I was like, oh my god, and I just moved so slowly. I'm like, we need to get her down. And they're like, oh, I'm like, no, now get the thing off her side, turn her on her side. They're like, what do you mean? I'm like, turn her on her side. They're like, I don't understand. I'm like, turn her on her side. She's aspirating. Like, oh my god. No, they're not. They don't understand. They don't understand.
It's like, it's like taking an IT guy.
Yeah.
into the hospital.
It's-
like, prevent aspiration.
Aren't they all at least BLS trained? Like, no, you don't think so?
They don't have any
it's like truly beneficial.
Should I be
Like it makes it so much
I met up
easier to
today.
see previous anesthetic.
Because I had another patient who
So
the
that
IV for
computer
pre-op
does so much of your documentation.
wasn't working, and the tech's like, "Cool, I'll do it." He's like so
I feel
excited.
like a lot of those it's not actually
And on top of
things
it,
harder, but
somebody else.
The Echo techs can do IVs too.
it's like really good.
So
We learned that.
That he was so funny.
he's busy.
Was it Rivka?
This is a really nice lady. She's shorter. Pregnant.
Yeah, I did one for her because the guy was like, he's like, "Oh yeah, they
I
were
like
doing
that
some
idea.
ultrasound,
I like
put
that
one in
idea.
on me," and he had like
Yeah, I think if you're gonna
like
be on nights,
AIDS, not HIV, he had AIDS.
just know that we
And she was like,
nights, you're expected
oh,
to stay up.
I was like,
hoping you can
I'll do
sleep
it.
every night.
And I was like, "You have a video."
I think that would
She was like, "Oh my god, thank you so much."
night foot person takes all the
I did
cases
one
that
when I
are
was with her.
scheduled
I
and
ended
then
up doing
trauma
better.
comes in. You're
We
still
only had
getting
one that we had
that
to
trauma
do.
exposure rather than going
Yeah.
to the backup APP. That's,
She's so fun. I like her a lot.
I think it could work out really well. I like
Think about it.
grabbing people.
Think about it. That's something that I've been floating that idea for about a year. It's not really taking hold. If we can let them think that's what we want to try.
Were you trying?
We're leading them.
Why do you care?
Wow.
Those fighting words.
Wow. I'm never talking to you again. I don't care if you're in my QI group.
The possibility of, and I think I talked to you about this, Brooke, of, you know, the two complaints that we're having
I know exactly what you're going to
say.
I know exactly what you're going to say, yeah.
So, you know, people that are just in general health, that's something that they enjoy.
And the APPs are refuse to do cases at night.
So I have 2 residents on at night?
So have, yeah.
Oh.
Make them cover only during the day since they don't work at night anyway. They get paid to sleep. Literally.
Oh, there's somebody telling me that they're short in the OR, so this accomplishes them getting an extra body in the OR on a reliable basis.
But they probably love that shift.
Oh, they love
This
it.
is what I'm saying.
Yeah, because they get paid to sleep.
And then on top of that, you have a backup resident that most nights will still be able to get some sleep in, right? So it makes it more enjoyable.
Alright, that's a good idea.
Think about it, just flip it by hand.
Yeah, you have like
So you're saying the CRNA would still be there or no?
no,
No, they would go to
Yeah,
day.
see, that's where you're gonna get pushback though.
'Cause they're
They
like-
love that shit.
they're like, I get paid for being on call and I don't do anything. Like, okay, most people don't have jobs where they could get paid for doing nothing.
Well, what's funny is that when I go back to Howard and I talk to him about, well, it's a satisfier for the ABPs over there to be doing cases at night because they take higher call frequency, and that's something that they do for their whole careers. I say, well, that's true. That's a satisfier. If you're taking completely alcohol, then that should be better.
Last time we were there, they were complaining that some of the APPs were coming over here because they didn't have to take night call when they're here because they had dedicated night.
Yeah, that's true. They probably have. That would be fun. It's always fun to be.
The fiasco of Denver. So we'll go ahead and get started. I know that the ORs are having trouble getting people out. It's the new normal. Before people get too settled, I want Glenn and Brooke to come up to the front.
See, I told you. I was like, if we sit in the back, we're gonna get picked on.
So glad you got me.
And Josh, since you're getting close, why don't you come up here?
Yeah.
Alright. I'll sit one row back.
We've been out with the OR for a month. We don't know anything anymore.
Hopefully it's echo.
So I'm not going to ask you any echo questions. No, I'm just kidding. You guys.
That's very mean.
This is one of the nice things about this session is AB's made a change for this upcoming year. So it used to be that you had the TEE station completely separate from your patient monitor station. This year they are actually combining those two. And so we'll go through the content outline briefly to see what that station looks like, because we have one scenario that is just patient monitor, we have one that is just TEE, and then you have one that is combined, where you have an image of both. So we'll go through some of the examples. Again, when you're actually getting ready for this exam, go to the ABA website. They have fantastic things to look at in terms of how to prepare for the exam. So this is from the content outline. Let me see if I can blow this up a little bit. And I'm going to show you some videos, show you the way that things are scored. All right. So you have a physiologic display, and I'll kind of take you through their examples, their videos of what that looks like. From echo readings, 3 scenarios. As I said, just one with the monitors, one with the echo, and then one combined case. Each one is going to have a short case description at the beginning, and then there's going to be simulation of either the monitor or the echo that takes place after that step. The examiner is going to ask you.
TE or TT?
This is TEE. Yeah. The examiner is going to ask questions, and you just respond verbally. Really, we'll look at some of the answer keys that they have. You'll find that don't overthink this. Say what you see, and just be very basic about what the images are showing you. They're not trying to hide anything. They're not trying to trick you. It's not anything that is subtle. These are usually very obvious things. Okay. So for the monitors scenario, you have about 2 minutes for that. They're going to show a recording. I've got some examples that we'll go through that I created. They're very much poor man version of what you'll see, but the idea is pretty much the same. So what's going to happen is you have 45 seconds after you've watched the video. to answer just 2 questions. And the questions are what changes did you see and what's the most likely diagnosis? So you want to be thinking to yourself, what was different from before to after, and what diagnosis is supported by those changes? So with that said, let's go ahead and check out a scenario. So you can see that it's showing you a countdown on the bottom right-hand side. You get about 20 seconds to read the stem, so why don't you go ahead and read it. So there's the physiologic data. So take a moment to look at that. So as you can see, you have lots of time to look at this. Right? Most of the changes occur pretty quickly. All right, so Brooke, what changes did you see on the monitor?
The patient became hypertensive, the heart rate was increasing, and there were ST changes in V5.
Do you see them elsewhere?
Hmm?
Do you see them elsewhere? You said V5.
Not from here.
So it is hard to see unless you're closer. There are also in 2.
In 2.
So 2 and V5 see ST changes. So what ST changes do you see?
In 2 and V5.
But what ST changes specifically? Right, there's a couple of changes that you can see.
Oh, elevations.
So with that said, what would be your most likely diagnosis?
Myocardial infarction.
Okay. So very straightforward. You can say myocardial ischemia. You can say STEMI in this case. The idea here is that you have tachycardia. And it's important to say what kind of tachycardia it is. Is it sinus or non-sinus tach?
Sinus.
So sinus tachycardia. You have new onset hypertension, and you have ST elevation in 2 and in V5. So very straightforward, very simple. This is the ABA's example. Okay.
So a question there. So like, I wouldn't necessarily call the diagnosis myocardial ischemia. I would say that he has ischemic changes, and then I would say, okay, why? Like maybe he's inadequately deep, maybe he's in pain, maybe he has other reasons.
They
Like,
don't want to.
they don't want that.
They're not asking you that.
Okay.
They're not asking you what could be contributing to that.
Okay.
They're just asking you, what do you see that's changed, and what is your diagnosis based on those changes by themselves? Very straightforward.
What's
This
a
is not
concern
something
for
if you're
myocardial?
talking for a paragraph, you're saying way too much.
They want like 1 or 2 words.
So this is the answer key. Right? It's super straightforward.
That's all. They're just looking at the sheet. Check, check.
That's correct.
Nice.
An idiot.
Well, if you said ST elevation MI, or if you said myocardial ischemia,
Like,
That would count.
probably count.
Yeah, that would count. So ischemia, myocardial ischemia, and infarction, for them, when you have an acute change, at that point, you don't really say that it's infarcted necessarily. Because
Right.
it's
You don't
just new
know.
onset, right? So it's ischemic injury, likely reversible. But I think if it were me on that scenario, I'd say you have ST elevation. I'm concerned about myocardial ischemia. Ischemia is my diagnosis. Any questions on that section? They have on here a diagram of the various things that you would expect on your physiologic monitor with all the different things labeled. Nothing on there should be surprising to you. What I will say that's difficult with the monitor section is that the additional information that you could be tested on doesn't always show up on here. What do I mean by that? There are things that you would see potentially on a Swan-Ganz catheter monitor that they could show you. That is something that is testable. Nobody's ever said that they've seen that monitor yet that's actually gone through the exam, but that is something that you may be asked because they can ask you questions related to your wedge pressure, for example.
Jake Anton wants you to speak more into the mic. And then I'm really loud, but you're quiet.
Can you hear me better? So the other thing is like on here with the cardiac output, things where you're looking at SVR, cardiac index, things of that nature. You'll have to be aware that that is something that you could be asked about that could show up. A couple of important points about the simulation features. If you have a low signal, that could be because your O2 sats really are low, or that you're hypotensive and it doesn't show up. You don't have that pulsatility waveform in order to get a reading. Everything is defined by color. If you're colorblind, I'm sorry, but that can be something that will help you figure out what's what. One thing that I don't know if you noticed when we watched the video, there's the alarm window at the very top of the screen. So if there's an alarm that pops up, you'll be able to see what that is to just help clue you in. You hear the sound, you see the banner up at the top to know that that is an alarm. And then if for any reason you feel like you can't decipher a signal, so let's say that you didn't really appreciate any changes, let's say it really is something that was very subtle, you can ask for clarification of the examiner. Now the examiner, as they showed it in their video, that was a continuous video of the changes in real time. That's called a dynamic change. They can have a static change to where they show you either a single camera image or a single before video that shows what that patient status was before, as well as one that's an after. So when I go through the examples that I came up with, that's how we'll do mine, is a before and after scenario. But you can always ask for clarification if you need it. So that's really the monitor section. Any questions about what the ABA provides you for information? Okay. So with respect to going through some things, so this will be for you, Glenn. Why don't you read the stem?
All right, a 43-year-old female with a liver mass is undergoing a partial hepatectomy. You're placing a thoracic epidural in a preoperative bay. While you are searching for the epidural space, the patient complains of feeling funny.
Okay, so this was the vitals before you started your procedure. Those are the vitals after. So first off, what changes did you see?
So changes are the patient became bradycardic, sinus bradycardia, with a decrease in SpO2 and hypotensive.
Okay. And your diagnosis?
Possibly a vagal response.
Yeah, so that's exactly right. So vasovagal response is what this scenario is. You have that supported by drastic decrease. So if you go back to what it was supposed to be, starting off, this is one of the advantages, I think, of practicing this is you got to take a snapshot. What did we look like before? We had normal heart rate, good sats, normal blood pressure, and then we have to change. You correctly noted we have bradycardia. You see P waves, so there's sinus bradycardia. We drop down, we are hypoxic and hypotensive. Right. Any questions on that one? Yeah.
Could this be a sympathectomy if there had been an injection afterwards, or?
Oh, certainly.
Okay.
Yeah, you're exactly right. So the idea is to really take that stem here, and the wording matters, right? You are placing an epidural. And while you're searching for that space, so you're in the process, you haven't administered any drugs. So the next step was you have placed an epidural and you have given a test dose, let's say, for example, and then you get that change, then that's certainly, you could say that you have a spinal that you've inadvertently provided the patient, or that you have either pushed too much medications and you have a high epidural. Any other questions on that one? All right, Josh, scenario 2. Read it for us.
66-year-old female is undergoing a right TKA. You just completed placing a single shot AC nerve block as you're cleaning out your monitor alert.
So, again, this was before you started the procedure.
That's familiar.
That's correct. That's all normal, right? I want you to sit in front, Janine.
Okay. Jake Enton asked if you could tap him in too.
Tap him in too? Yeah. All right. If he wants to get on speakerphone, I'll have him do that.
Okay.
Here's the change.
Okay. That's pretty good.
So, what changes do we see?
We see asystole and no reading for SpO2 and no reading for blood pressure. So,
Diagnosis.
Cardiac arrest.
Secondary to what?
Probably intravascular local anesthetic injection. Probably last.
Good. So that's exactly right. This is very obvious, right? You have a very abrupt change, drastic change from one scenario or from one situation to the next. But again, most of these changes are going to be very obvious. All right, Janine, this is yours. Why don't you read it?
71-year-old male with a history of arrhythmia is undergoing an inguinal hernia repair. 5 minutes after you completed your preoperative evaluation, the nurse calls you back to the patient bedside for evaluation.
You feel like you have understood that scenario?
Think so?
Okay, so there's what the bottles were before. And this is what they are after.
Right. And so it looks like it was regular. I'd say it looks kind of like fluttery. I'd say it's atrial flutter.
So so that's true for your diagnosis, but
Right.
also, so the first question is what changes did you see?
Okay.
So there's your original scenario. There's your new scenario. And then
Go back
what
to
is
the
your
original one more time. Sorry. Okay, I'm good.
and then so what did you see change?
So I saw a change in rhythm, a slight increase in the heart rate, and a decrease in the blood pressure. No change in the
And then your diagnosis you're saying then is
you
said it.
atrial flutter.
Yeah. So this would be we might say atrial flutter. Does anybody know what the conduction ratio is for this?
2 to 1, 3 to 1,
3 to 1.
3 to 1. Right? So remember you take 300 divided by heart rate, and that tells you your number. So 3 to 1. Any questions on that one?
Do you just say what it's from, or just say okay?
No. You used to potentially come up with a differential diagnosis in the past. So one thing that you missed before you came in is that they are joining the TEE and monitors stations together.
Oh.
So in that, they're having to fine-tune how many questions you're asked. So for the monitor section, it's simply what has changed and what is your diagnosis. That's it.
Okay.
All right, back to you, Brooke.
79-year-old male with a history of coronary artery disease is undergoing a 5-vessel CABG. Left radial arterial line was placed prior to induction. Anesthesia was just induced, and an endotracheal tube was successfully placed.
Again, same pre and post. And that number is 190, both spots.
Okay. For changes, I see change in rhythm and hypertension. And is the end-tidal CO2 gone, or is it zeroing?
It's right here, so it's called
okay.
mid-exhalation.
Okay. And ST elevations.
Good. What's your diagnosis?
Myocardial ischemia?
So this would be something that would be an intraoperative problem. ST elevation, as you said, leading to myocardial ischemia is what you're worried about here. So you hit all the high points. Change in your rhythm, ST changes in your EKG. You have hypertension. There's been no change with respect to your capnogram, at least not appreciably, that gives you any information. And then the other thing that kind of shows up too, whenever you have irritability in the ischemic tissues, you have PVCs that show up right there. Any questions on that one? So tell Jake to call you so we can put him on speaker if he wants to participate.
I don't know, he called me a jackass after I told him he was next.
He's like, I really don't want to participate.
All right, a 54-year-old female with a history of GERD is undergoing a Nissen fundoplication. A right internal jugular venous central line was placed after induction because of difficult IV access. The case has been uneventful so far.
All right, so this is what it was before you put the central line in. This is after the change.
Okay, so changes, the heart rate has increased. The EKG is showing what looks like a irregular rhythm or loss of ectopy. The SpO2 is unchanged. The blood pressure is decreased now and hypotensive. And then we didn't have a CVP before, and the end-tidal CO2 has also gone down.
What's your diagnosis?
Diagnosis would be ectopy from the central line wire. Or did they place the central line?
So the central line was not on the other tracing, so you don't have anything for comparison.
Right.
However, kind of take a look at the constellation of things. Let's presume that placement was uneventful, surgery was going just fine, and then something changed, and it changed abruptly.
Some sort of possibly venous air embolism.
So it can be an embolic phenomenon. What might clue you in to what's going on with this and that?
Pneumothorax?
No. Any other thoughts? Tamponade. Why do you think tamponade?
Narrowed pulse pressure, and it's a Nissen.
Yeah. So you have a Nissen procedure. They're working right by the heart, and if there's any injury to the myocardium, you can bleed into the pericardial sac. So that's what this is. This is cardiac tamponade, narrow pulse pressure, tachycardia. You said increased heart rate, but I want you to use the words. Sinus, what appears to be sinus tachycardia with some ectopy, some PVCs that are in there. Hypotension. This is something else that might help clue you in, right?
Yeah.
How does that help you figure out that you have tamponade physiology?
Decreased venous return.
Right.
Pressure on the right
You can
atrium.
get filling of that RV and everything starts to back up, right? So this one's a little bit more complex, and I actually chose this one because this is something that happened to me my very first year as faculty.
Ooh.
It was something where Schoen was doing this exact procedure, and he actually took a staple when he was doing his staples along the gastric line and actually punctured through the diaphragm into the LV.
What'd you do?
Maybe it was RV. The patient coded. They went on to bypass. Ultimately, she did fine, but it was crazy. He did not have a central line in it.
Crazy. Yeah.
That's crazy.
That's a nightmare.
Interesting.
So this is a bit tougher, but again, use the constellation of things, right? You know that you didn't really mention this in terms of changes, but it's abnormal for it to be high, right?
Right.
So that's something that you should clue in and say, well, take it at face value. They're showing me something. That's not a normal value, so that has to be something that is contributing.
Can you go back to the stem? Oh. Case has been, so that implies that like the case is already going.
That's right.
Okay.
Josh?
12-year-old male in otherwise good health with appendicitis undergoes an RSI anesthesia. Once the endotracheal tube is secure, you observe an abnormality on the patient monitor.
And so I'm not showing you before because you just hook them up and this is what it looks like.
So normal sinus rhythm, normal heart rate, normal SpO2, but his CO2 is a little bit low and the waveform looks, there's no plateau in the waveform.
And so what's your diagnosis?
Probably some sort of reactive airway disease, so maybe an asthma attack or something like that.
Yeah. So bronchospasm would be kind of the single word answer, but reactive airway disease I think would count just fine. The idea is you have an obstructive pattern to your waveform. Questions on that one? All right, I think this is the last one. Janine?
You're called to the PACU to evaluate a patient cared for by one of your colleagues. He is a 29-year-old male, status post multiple split thickness skin grafts to his legs and torso.
Again, you just met this person, you don't have any before for comparison. What abnormalities do you see?
So I see tachycardia at with a regular rhythm. Looks like sinus tachycardia to me. Normal SpO2 and hypertension.
What's your diagnosis?
Pain.
Good. So, again, straightforward, right?
Yeah.
You go into PACU, you have somebody that's tachycardic and hypertensive, you have to rule out that pain is not the cause, right? So that's 1, 2, 3 in your PACU tachycardic hypertensive patient. All right. Any questions about the monitor station? To me, in years past, it was much more scary because it was its own station and asked other questions about how you would manage the change in vitals. It's now, I think, very straightforward and easy, so you shouldn't stress about it. All right. Second part is going to be the echo portion, so that is going to be, let me find my bag real quick. There's going to be a sheet that they provide you on the desk that shows you all the TEE views that you need to know. And so this is something that's on the list. So what's going to happen is they're going to show you the image. You're going to look at this and you're going to tell them what view it is that you're looking at. So that's one of the things that you have to say is what view it is. And then you have to describe what you see in the echo. So you describe the echo findings. Again, just calling attention to things that you see that are abnormal. Provide what your diagnosis is based on those findings. And then this is where you would talk about management. What you would do to manage and why. All right, so let's go ahead and look at the ABA's sample video. So again, you have a stem, bottom right-hand corner, you have time. So you start off with 30 seconds to read that stem. Here are your images.
Am I going?
Not yet.
Okay. I'm on it.
So this is the tough part about the OSCEs. You have to watch the whole image until the video ends.
Oh, I wasn't
That's when you
watching.
ask the questions. Yeah, watch the video. Glean all the information you can from what you're looking at. What view am I looking at? What structures am I looking at? What's abnormal? So I'll fast forward. For those of you that can't see the clock over here, you start off with like 2 minutes for this. It's a long segment. So I'll fast forward. Do you feel like you've had enough time to look? Glenn, you're going to be the first person.
Well, I get all 30 seconds. Let's see, here we go. Short axis and let's do a long axis. Yes, I'm ready.
Okay, so I'm just going to pause this video then. What views do you see?
Midesophageal aortic short axis and midesophageal long axis.
Good. This one being the short axis, this one being the long axis. What abnormalities do you see?
Aortic stenosis, and I guess along with that, some valvular abnormalities on the aortic valve.
Being probably what?
Calcified aortic valve.
Okay. Any other abnormalities that you see in any other structures? Let me play this video just a bit longer. What do you think about the thickness of that?
Yeah. Left ventricular hypertrophy.
Yeah. So for this particular one, if we go to the answer key, you hit, I think, all of the main points. Oh, we didn't talk about management at all, but we'll talk about that in a second. So, thickened valve, which you talked about, calcified, right? Poorly mobile. You did talk about aortic stenosis, so that would really be the main diagnosis that you see from what you're given. But you also see that hypertrophy of left ventricle. I think that's something you should expect when you see a valve that is stenotic, not moving well, is that you're likely to have corresponding LV hypertrophy because of that. And then the second set of questions I didn't ask you, so how you would treat that. The patient, I think in the stem was hypotensive, is that right?
It says unstable.
Unstable,
Yeah.
right? So you could say that they probably need volume, they need something to improve SVR, heart rate control, and then refer them for intervention of that aortic valve if possible. So very straightforward answer key, right? You hit most of the things here and there. We didn't actually ask those questions, but you would have got those as well.
Heart rate is.
Any questions on that video? So for some sample videos,
Really?
Get out of it.
You felt good at the act.
Just say the teaching was limited on cardiac.
Well, this is why we go through it, right? All right, so the way I've got this listed right now is that all of the images are from the same patient until they say, so patient 2 would have different images. So all these next ones are going to be from patient 1. Is this going to work? Perfect. So what's the view?
Esophageal floor chamber.
Good. And let's see if this will play again. It's not supposed to stop. I don't know why it did.
I think it did this last time. It only played once, and then no one could get it to replay.
Is that right?
Yeah, just remember this.
That's very interesting that it did that. So you're correct on the view. Was there anything in the short period of time that you saw that looping that you saw that was abnormal?
It looked like a little bit of decreased LV squeeze, maybe some overextension. I didn't really see the valve, so I couldn't comment.
Yeah, so not a whole lot that was abnormal there. This one, let's see if it will do.
Transgastric mid-papillary? I'm not sure.
Correct. Yes. And so what is this structure here?
Structure where? Sorry, I can't see your cursor.
Let's see how I can do this. It's up here.
Yeah, yes. I mean, that's the LV, if that's what you're asking, but I don't see your cursor anyway.
Yeah, I'm trying. It colors it on here, but it's not coloring it on the screen. So let me just use my hand. They would use a cursor.
Yeah.
They could use a laser pointer or something to point on the screen. So what is the structure here?
LV,
What's the structure here?
RV.
Before I play this, what's the view?
Oh gosh, that's the same one Glenn was saying. So the mid-esophageal, it's the short axis. I'm not sure. Aortic valve short axis, maybe.
That's correct. So what is this over here?
So that's I think the right-sided inflow or outflow. I think so. That's pulmonary artery. No, the other side is pulmonary artery. So that's the inflow. Yeah. So that's RA or RV. RV there. Yeah. And then
So this would be your pulmonic valve right here.
Yeah.
Aortic valve. Anything I'm missing on there, Glenn?
Nope.
Alright, so let's look at the function. Anything abnormal that you see there?
I mean, good squeeze, maybe a little hyperdynamic, but nothing
Okay.
grossly abnormal.
Good. So nothing grossly abnormal. What is this view?
Is that the long axis aortic valve?
Good.
Mid-esophageal.
Esophageal
Long
long
axis.
axis.
Almost all of them are mid-esophageal, so that's a word that you'll use a lot. And that was much shorter.
I didn't get to see what
I
that
was
was.
doing that.
I forgot to look.
Looks like the valve's opening.
It is. It is unremarkable.
Okay.
Patient 2. We're going to move on to Janine.
So wait, that was just a completely normal exam then?
Yeah.
It was so tricky.
Okay, I'm ready.
So, what view, can you tell what view that is then?
No. But maybe it's if I were to guess, maybe the mid-esophageal two-chamber. But
So let's play this and see if you still think so.
the mid-papillary, is it transvaginal mid-papillary? Is that what it is?
Yeah, it is. And what do you see abnormal?
It looks like there's some left ventricular hypertrophy. And I wasn't able to see the squeeze too well because I was looking at the sheet for too long. But I would say some left ventricular.
So, yes, and also...
The septal wall looked like it wasn't moving very well.
Right. So you had regional wall motion abnormalities. Really, this whole segment over here wasn't squeezing the same way it was out here. Are you able to tell what view that is?
It might be the mid-esophageal four-chamber.
Okay. So let's look at the...
So you definitely still have that regional wall motion abnormality at the
Good.
symptom.
It's pretty
But the
Right after reperfusion.
collateral wall seems to be moving well. And the valve looks okay to me. There we go.
What else did anybody else see?
I didn't see it.
Okay.
Does the papillary muscle look kind of big?
Yeah, I mean, so maybe some dilation, LV dilation, right? So you're not getting great squeeze, and so EF on this patient likely is to be low. Brooke. Let me go back real quick. Okay. I'll tell you right now that the this patient is presenting for double lung transplant because of sarcoidosis.
Mm.
Before I start this, are you able to tell what view that is?
I'm gonna guess that it's the mid-esophageal four-chamber, but I can't really tell from here.
Okay, so let's go ahead and start it and see if it becomes apparent.
Whoa.
Oh, this is the Wait, do you have to know that one for this?
No, I think that is the mid-esophageal
I think
floor.
it is. It's just weird, right?
What is it?
What is it?
What?
Yeah.
Yeah, it's the mid-esophageal four. It's just Wonky.
Yes.
Yeah.
So some of these images are not going to be out in your perfect image. Some of them will be zoomed in a little bit more. So getting your bearings is going to be the first challenge for you.
I didn't look at it when it was moving.
I know.
I mean, the RV is very big. RV is dilated.
So you have dilated RV, right? So that's what this is. And what would you say about your septum?
Thickened. I can't tell from here. Flattened.
Thickened?
Bowing.
Yeah. So
I'm just saying words that I think might go. Because I didn't see it.
so thickened, yes, and it was bowing when the RV was contracting. So that's a sign of what you would expect in this kind of patient that has had lung disease, is that they would be showing what on the right side. What are they suffering from in terms of pressures?
High pressure.
High pressures, volume overload, right? That's what they're showing. How about this one right here? Can you tell what it is before I start it?
Is this like transgastric? In a weird way?
Yep.
Nice.
Oh.
That's a good example.
Yeah. I would call that septal flattening.
Yeah.
And LV hypertrophy.
LV hypertrophy and septal flattening. So this is that D shape that you get in the left ventricle when you have these kind of patients. Back to you, Glenn. Hey, you want to chat? Good segue if you want to say hello.
I actually don't know how to do this.
No?
They gave me this. I don't do very many technical presentations. I'm going to start by apologizing that we suck so bad right now. And in March, we have 9 people starting. So you just hold on to March, or eventually we'll start in that rotation.
or you'll graduate.
Or you'll graduate.
Oh, yeah.
So there is what it is.
And stay here.
Yeah.
See, doesn't that look like the wrong thing?
We have to live with that each day.
Yeah. There was no such thing.
Which one?
It was actually like 8:30 every time I was late. Yeah. Do you guys, did someone tell you guys about the STICU to OR handoff that's happening? I sent out, I think, the slides to the chiefs.
I think they sent it out.
Okay. You guys don't do a lot of STICU patients, I don't think, so I'm not sure how much you wanted to know about it, but do you have any questions? It's been working really well.
I think on the weekends they do for a number of.
Well, the weekends, it's the weekends. There's absolutely, I don't know what happens on the weekends. It's all kind of, every man for himself. So that's fine. All right. Well, if you ever have any questions on the STICU should be, if they're intubated, the RT puts on scrubs and walks all the way into the OR with you. Always there should be a CNA in scrubs to walk all the way in the OR too. If you give them a 15-minute heads up, the nurse is to pack up the patient, and you come up there ready to go with your transport help to roll into the OR. They will then take their monitor back. You'll take the patient back at the end of the case. So it actually has been working very smoothly. There's been no arguing. The only thing to remember, it's only STICU. So today there's an argument between neuro ICU. They don't do that transport, so if you do a neuro transport, don't yell at them because they don't do that process. It's totally different. Burn is going to roll out, I think, the same exact process, but that'll be like March 7th because this process is rolling out March 2nd, and I felt like we can't stress out the nurses too much.
Do they come and help you take the patient back, or you do that on your own?
You know, they actually have been, like, if you need them, they have been great about, if you call them, they've been coming. So it's actually been very collegial. Everyone has gotten along, and it's gone great. So if you need the help and you call them, they've been able to come down and help. So it's been nice. This process, you can read all this if you want. We've had an incredible amount of QIs on patients coming to the OR, not marked, no consent, no antibiotics, the list goes on and on. This has been at least 10 years in the making that I've had to sit in QI projects on this. So the hospital took a real, they wanted this fixed, so they hired PI improvement people to do all this, and then this is kind of the background on why we're doing it this way. It's seriously been, this is all the consent errors that they've had. This is the sticky notes that we had to go through to get to this process, in case you guys ever want to do a PI process. Highly recommend. Staples is definitely your friend if you have to do it. So this is what they are recommending. How it will work is that the RN in the room and the pre-op RN now are going to do a handoff to each other. The OR nurse is the one that's pushing the patient back. So you guys will no longer be pushing patients back. I would not bring this up in any way to the nurses right now. They just found out about this. This has been months in the making. Remley actually switched over in December to this. They caught 57 consent errors in the first 2 weeks. So this process, as much as the nurses didn't want to do it, is never going to go away because it was so successful in catching errors. So what will happen is that what you need to know is please, please, please make sure that hop in, do your consent, get your stuff, get out. Just don't bother anybody, do it. If the nurse in the room needs help, we've said just call, if the patient's anxious, we're not writing for Versed or anything like that because that's just more stress for them. Or they're stressed because it's a difficult bed or a big patient and they ask for your help, please just help them out. It's totally fine. We've said no problem. If you need help, we'll help you. The nice thing about it is if you have these big cases with spine, neuro, where you're doing all these drips, you no longer have to wait to set everything up because you can sit in the room. So it actually should help with our spine turnovers and our neuro turnovers, which is another PI process going on. And I can send these out. These are all just the workflows, which I'm assuming you guys don't really want to know. So any questions on what will happen?
So the OR nurse will check in with us at some point to say, are you ready?
Yes. They'll probably be in a less friendly tone,
Why are you so slow?
Does John Pham know? Because now we can take out the midazolam from our narcotic bags.
Oh my god.
No, don't tell him.
We don't need midazolam.
An email to the group was cruel.
Our
I don't think anyone
midazolam,
told him to do that.
our midazolam usage is going to plummet.
Well, it probably will.
Yeah.
And AOP is particularly not happy. So in Remley, if the nurses are concerned about it, Remley, they have 5-minute turnovers. And initially when this rolled out, because I was on this initial process, I was pretty concerned because that's obviously they don't have a big setup, but it's still a tight turnaround. The first week, they went up to 9 minutes. And then after that, it's gone down. And they actually all enjoy it. There's a part in Epic where both nurses have to sign in and acknowledge that they're doing this handoff. So we don't even know I don't know where that is. So you guys are not expected to know where that is or how to do it. The important thing is that you have your stuff done, communicate with the nurse in the room. If they need help, they should ask you. But otherwise, March 2nd, you no longer will be pushing patients back.
This is how it's done at Children's, and it's impossible to make the turnovers without it. It does make the turnovers a lot quicker.
We do 15-minute turnovers there, and it's
regularly.
And most of it is because we don't have to go back to the OR, set everything up, then walk all the way back. And then,
right. Yeah. And like I said, Remley, it's very successful, and they've caught a ton of errors, so this is not going to go away. Some people have said at other institutions they actually wrote in the pre-op orders for said, but we're not going to do that now. We're going to maybe see how the nurses get along. This is very traumatic for them. When I told the ABC group at our meeting about it, I stressed not bringing it up with the nurses because they are very upset. That did not happen. One of them made a joke, led to a whole thing. So for reals, they are tense. I mean, as stressed as we are, not having great people, this is much more stressful. So just try to be very open and accommodating, as you all are anyway. So.
Are we going to get rid of the delay reasoning on our end then, since I'm assuming we're not really going to be
the delay.
Yeah.
And honestly, I don't even know if anyone really reads those because we were trying to use them for the STICU. We were trying to like gauge how it was going for when we did the pre and post, this kind of turnover for STICU. The nurses put in different codes than we do, and no one looks at them. So honestly, I don't know. Right now, they're just trying to get to a place where they can maybe step back on the lots and lots of QRs.
So if they ask for our help bringing someone back, we just have to make sure that they've done their handoff.
They have to do the handoff. No matter what, they have to do that handoff. You are strictly kind of a transporter at that point because they are the ones that are in charge of making sure that handoff is complete.
If they say, I have to do this other thing, can you go get the patient? Or do we have to be in their presence to bring the patient back?
If they've already done the handoff, then I think that would be fine. I would kind of hesitate moving into that though because that will come up. That's a very slippery slope. So I think we should really stress the process, and I'll go over that with the OR nursing leadership before March 2nd, that we really need to stress this process because it is going to slow things down even more so now, which is nice because we don't have any break people. So you get your so again, upside, you get your breaks. And you don't have to push it out. Yes.
So at Children's, which is like the only place where we do this. If someone gets a pre-med, like we have to be with them. Mm-hmm. Same rule.
That would be here. Yeah, you have to be with them. So, yeah, it'll be interesting to track. You can tell John and to track how many years I give her some things to do. Any other questions? Sorry to interrupt you guys. Sorry, there's like half of you here.
So any patient that gets blocked with pre-meds and pre-op, we're going to have to go out.
No. Those patients are okay. I mean, they've been blocked. They've been there. Just the ones that you immediately, they've already been monitored and whatnot. I would say no on those. I can ask just to be sure, but I wouldn't. Because also, who knows how long they've been sitting there blocked with our delays. It could be a while. I gave someone Tylenol today, like 2 hours before they went to surgery.
Are we gonna get an email with all this?
Yeah.
Or have it? Okay.
Yeah, I will send one. I'll send one to the
It's
chiefs,
the
and then they will disperse to you guys.
All the
because I don't
residents,
know
too.
what your.
One of the nurses said something to me about it yesterday. She was like, "Did they tell you about what we have to do now?"
Just say
And
no,
I was like,
I can't
and I
wait to look
said-
forward to
I said,
it.
"What?"
Thank you for the opportunity.
What? She was like, "We have to take the patients back now starting in March." And I was like, "Oh, awesome." And I was like, "Great, that'll help our turnover so much." And she was like, "How are we going to get anything ready?" And I was like, "We do it."
Is this going to apply to every patient, like cardiac patients, transplant patients too, or just?
I would assume yes. I don't know what cardiac does.
Cardiac already does it.
Really
Cardiac already does it.
So I don't know.
Cardiac nurses already go get the patient.
So
all
then,
the
yes,
time.
transplant. Every other patient should be because if there's been no
I've
service
never had it.
excluded
You can ask
from
them.
these errors.
I've never had it.
So
I
didn't know
the
that.
only
They
place that
trialed
wouldn't
it.
happen is MRI because they don't have those.
And the nurses
But
were
it's,
like,
if you think about it, that's how CDC has been doing it.
They are.
I mean, their nurses always.
the
bring
nurses
their
were like,
patients
yeah,
in.
we'll do the
So,
patient. Of course we're ready. Let's go. Why are we waiting?
any other questions so I can get Tony back into what seems to be a stimulating if you guys were all just chatting away in here. I know. I did, in fairness, ask if I could bring booze, but Dr. Myers said I was not allowed to. Which
Thank you for asking.
We could go to the bar later.
See?
Bye, guys.
Thank you.
All right, we just have a couple more, and then we'll get the first last segment here.
It's crazy. We're not allowed to do
We're not
from the nurses.
Apparently, we're not allowed to be happy about that. But this is huge, you guys. That was like,
People have been
huge.
wanting this
I'm
for
really
so
happy
long.
about that.
Yeah, you should be super happy about this. This will save you in your entire residency like
Yeah.
hundreds of hours.
The nurses were like complaining. I was like, so look, we have to drop the patient off at PACU, then we have to tell David that they're not okay, and then we have to walk all the way back to get our drugs. Then we have to go see the patient.
How long has that been waiting for you? Just been like,
Hey, if they do this at the VA, it'll
Like, I'm not gonna
add
be ready
half
for
an
like
hour to the
3
journal.
weeks.
Yeah, they're not implementing
Yeah,
it yet.
Decrease.
Do they do that?
The number of hours of my life is
All right.
We
Did
get
we
them.
leave off with
Nothing would ever happen if it was like other nurses.
It's Glenn's turn.
I think it's my turn.
So this next patient, recognize that view?
Yeah, it looks like the transgastric short mid-pap. Something called it. Mid-pap short axis.
Ooh.
I kind of missed it. Just
Bad.
barely saw like decreased.
It's not moving.
Decreased ejection
right.
fraction. Was it hypokinetic? Hypokinetic. Global hypokinesis.
And
It was a little blurry. But it wasn't bad.
Metaesophageal four chamber.
Yeah. I look.
here's the video.
Again, global hypokinesis and dilation of the left ventricle.
So not moving much. Last view.
Metaesophageal long axis. Yeah, again, global hypokinesis and dilation.
So same heart, different views, showing the same global hypokinesis. Josh.
Esophageal four chamber, probably.
So yes.
It's like hyperdynamic and with low volumes.
Good. That's exactly right.
Some septal thickening maybe right there. And, transgastric mid-papillary.
Good.
Wow.
Very hypertrophied and very hyperdynamic.
Good. And hypovolemic too. Okay. Yep. W.
Don't forget to look at your name.
Yeah, look first and then read the list.
Oh wait, yeah, don't wait. So this is the mid-esophageal aortic long axis.
Good. Here's your view. What did you see there? Hey, Jane.
I think the walls are all moving. I think honestly, I was only able to look at the mitral valve. I didn't.
Good. So that's the one that's important. What do you know about it? Yeah, it looks floppy. So this one is kind of a color view of what you just looked at. So here's
There's a mitral regurg.
a little bit of mitral regurg and some prolapse, right? So that floppiness, that bowing back up into the atrium.
Oh yeah. There's
Do we have to know the leaflets?
So what now?
Leaflets?
No, I don't think so. Nobody said that you have to. Just big structures, but not knowing which one's people.
So if they
Or
expect you to
anterior
say,
posterior.
But you should know that.
so if it's a regurg case, they will put color on it. Is that right?
Yeah, if they want you to say that this is much regurg. From the first set of images that you saw, you could tell that it was prolapse, but you couldn't quite tell if it was regurgitation until they threw color on it.
Is there a better way, other than maybe some prolapse and floppy valves? Like, is there more correct?
Not that I'm aware of.
Just mitral valve prolapse
Prolapse.
of the posterior leaflet
Because you could see it.
Yeah, I mean, I can see it now. I just.
with a
Why is
regurg.
this one playing it, and the other ones are
So we were just debating.
The other ones say like JPEG at the bottom.
Did they?
Yeah, this one
But
doesn't.
that doesn't make sense because they played. Isn't a JPEG a picture? They did not help us.
We need some AV help up here. I think this is the last one. Yeah, Jane, come on up. You get the last one.
We'll do it together. We'll do it together.
I never got
So
one.
we've been reviewing the TEE and monitor station. So what we're reviewing right now are TEE images.
Okay.
So this segment is identification of your view.
Okay.
You'll have that list in front of you when you take the exam.
Okay.
They'll have you identify structures in that view, and then whether or not you see abnormalities in that view.
Okay.
They may ask you questions about, well, given the abnormality, how would you manage?
Okay.
I don't even have the benefit of seeing all the other ones and taking those off of the.
No, there's a lot of repeats.
There are
Oh,
repeats,
yeah.
so there's not-
All right, and just
But you
in
still
this
don't have that
scenario,
benefit.
you might have anywhere between like 1 and 5 seconds to look at the image.
Yeah, it depends
They
on
don't
whether my
necessarily
Just so you know.
So yeah, look at the video first, And then everything else. Ooh.
So this is the first image.
Okay.
I'll play the video in just a second, but once you kind of look through your list and get yourself maybe thinking of what this could be.
Oh.
That one.
I would put that word in there.
Yeah.
Right.
I definitely see that, but so you think of this one?
So it's a zoomed in image.
Oh, I think it's the.
It's a zoomed in this image.
Just like the
Oh,
focusing on
long
the
It's
base.
common.
Because I definitely see.
Or
It's ascending.
It definitely looks like aorta. I just.
Is it working?
Isn't that ascending or a long axis? It's not where you see the valve. Like if you see it,
esophageal.
yeah, but if you see a valve, they always name it after a valve.
If you're mid-esophageal, I think we can ask him, but there's no other way. I think that's what this is referring to.
So what does he think it is?
Probably.
Mid-esophageal ascending aortic long axis.
Yeah, I think
Or is that just the mid-esophageal long?
It's just long.
Long.
axis.
Okay. Okay.
Maybe it will be.
Mid-esophageal.
I don't know any.
I wonder what they mean by mid-esophageal ascending aorta.
Thank you.
Alright, so I'm going to play the video now. So Jane, why don't you go ahead and watch the video?
Okay. Yeah.
So given that you know what the view is,
Yes.
what is this structure up here?
I'm right. It's,
Yeah.
it's left ventricle. No. No. You're wrong.
First right.
Left atrium.
Yes.
So are you saying left?
Yes.
So
I was
if that's
definitely
the left
saying
atrium, what
because I
is
know
this
it's
here?
further. Septum.
That's that.
Okay. You're like nodding me before I'm even saying it.
Because I thought you were making mouthwash. Oh.
So,
Aortic valve.
good. So if that's
Yeah.
the aortic valve, then what is that?
And then that has to be left ventricular outflow, like the
Correct.
tract.
So this is the left ventricle,
Mm-hmm.
aortic valve, left atrium. What's this?
That's got to be right ventricle.
That is correct. Good. So then this would be the aorta. So what is this thing here?
That looks like dissected flap or
That's
a piece.
exactly right.
Okay.
This is deception. This is a different view. What views are these? You've got two views, the left and the right.
Those two.
We'll have Glenn do this one. We put you on the spot.
So that's the descending aortic short axis and descending aortic long axis.
Good.
Explain.
And let me play this so you can see what's going on here.
Ascending or descending?
It's descending.
Descending.
There's
Okay.
no descending option.
It doesn't have the mid-esophageal
So
part.
Tricky.
descending aortic aneurysm, the dissection flap.
Right. So the section. Right. I don't think they would ask you which is the false lumen and true lumen. Do you have a way that you figure out which one is which?
You'd have to see an EKG, but in systole it would move away, away from the true lumen, just like. Yeah.
So I think if I remember correctly, this is the true lumen here because as it was in systole, that would be pushing in that direction. And then this was the true lumen here because as in systole, this was moving in that direction. Alright, I think this is the last one. Josh?
Can I go back to my sandwich?
Yes, you may.
Okay, thank you.
I think that's mid-esophageal long axis.
Which one? This one?
That one, yeah, sorry, I couldn't tell. I don't, the left one I think is the short axis, I guess.
Good.
It's kind of weird looking, but
Yeah, so short axis, long axis. Mid-esophageal for both. And let's see what you can see here.
severe calcification and stenosis.
Good.
The aortic valve.
So you see that this thing's not opening very much. You got a lot of other artifacts, what looks to be calcification, so aortic stenosis. And then when you look at this image, you see that that's also not moving very well. And then when that was going, you saw some hypertrophy as well. All right. Any questions about TEE? It should be also straightforward. You need to know those 11 views, so it's just hammering those home. I actually have a handout that I'll send out that one of our CT fellows a couple of years ago put together that has the different views and then how they look kind of schematically. The other thing that can be helpful if you think this way, for some people I think it makes sense. You saw, let me put that image back up. Let me look at this image. You see how, let me open this up. It shows you
The plane and everything.
shows you here the angle. So this handout actually shows, not with absolute numbers on it, but kind of where that dial is on this half circle that you can use in addition to what you're seeing as verification that you have certain views. Because for some of the views, this would be over on this side, some of it would be straight down, so you can use that also as a way for you to differentiate from one to another.
And I'm sorry I missed this part, but we don't have to obtain any views, right, with a mannequin or anything. They give them to us on video and that's it. Okay,
that's correct. All right, so then the last thing that I just want to show you for the changes that they're doing this year is, pass it. There it is the combined case, right? So if you're looking at the red, you've got 2 minutes for that physiologic monitors one, 2 minutes for the echo one, and then the last one is the combined. So you're going to get 2.5 minutes for the combined. You're going to be presented first with monitor recordings, and then with the echo, this is of the same patient. The examiner is not going to tell you any additional information about the case, so don't bother asking. And when they do ask for questions, again, same sort of things. What changes or abnormalities did you see on the monitor? What findings do you see on the echo? So that's going to be the same. What most likely diagnosis do you have? The same. So it's the same questions that you're going to be asked. Just once is that the recordings will be played for. You can't go back. That's going to be true for all the other ones as well. So this is how it's supposed to look. So again, you can't see very well. There's a timer down on the bottom right-hand side of the screen. Starts off with 20 seconds for you to read the scenario. So again, you get a lot of time to look at that. All right, so Brooke will ask you the first question. What changes or abnormalities do you see on monitor?
Patient is in sinus tachycardia, newly hypertensive. It looks like ST depressions in V5 and maybe elevations in 2.
Okay. And what do you see on the TEE?
Looks like some hypokinesis and dilation of the left ventricle, more so septal than lateral wall.
And Josh, what do you think your diagnosis is here?
Some sort of infarct, probably LAD.
So let's go to their answer sheet. I think most of the high points were hit.
How far away are we going to be from the monitor? Like,
It's supposed to be
Yeah,
a computer
okay.
in front of you.
Oh, okay.
Yeah, because there were some tiny, it looked like the past blood pressures, I couldn't see them though from back here. So.
Right.
Yeah.
You'll be able to see it. It's clearly as you would in the OR.
Oh, okay.
Yeah, it's hard to project it up here, but it should be easy to see everything.
Okay.
So, sinus tap, hypertension, ST depressions, everything that you said. You talked about your septum. I think being a little bit more specific about you have wall motion abnormalities. You did talk about dilation of that left ventricle. I don't think you mentioned reduced ejection fraction, but that kind of goes in line with having a wall motion abnormality. And then the diagnosis, you said infarction, but ischemia would be fine too, so they have infarction there. So again, super straightforward. Don't be second guessing yourself or thinking it's hidden in terms of what it is. Any questions about this station? In my view, this station is the one that you can prepare the easiest for by going back and reviewing your images, reviewing your anatomy, reviewing all the things that you can see on echo or on monitors, and just being proficient with that. So it should be straightforward. Every single person will get this station. That's one thing that's changed with them combining it. Is they have a couple of stations that you may get or you may not get. And this is, with the change, them combining this as well as a different station for communication, you're going to get this, every single person will get this station. Any other thoughts, questions, concerns? Cool. That's all I got for you. Thank you.
You all might have noticed our QI project in the PACU is underway.
I like it.
Sweet. So
I've only got one phone call.
the three things that are changing are all the calls are going to go to residents now, and this is just for resident cases, not AAs or CRNAs. And it's really good for you guys to learn to manage PACU issues because you'll do that at Children's and other places you'll be called first. So it's really good practice for you guys. If you have any issues, just call your attending and they'll take care of it. If you can't go see the patient, but we're trying to encourage you guys to go see the patients if you can. Obviously, if you're busy in the OR, don't worry about it. And if it's an emergency, just tell the attending to go see it. And then the PACU nurses are going to be completing, they'll call you for sign out at the end of your PACU stay, let you know how your patient did so you get some feedback there. And it's just super quick, informal. It's not supposed to like grade you, it's just supposed to be for your feedback only. And then they're going to fill out an online form that's really straightforward and simple for them. And then at the end of the block, we're going to send out a cumulative, like how your patients did impact your nausea, pain, things like that. So you can kind of adjust your practice based on that.
And there's like clear answer choices that, because I know one of the questions was was the resident available and stuff like that. So if it's I came directly here from dropping a patient off. So
right.
Is there an option it's
yeah, it's after 3 p.m. It only goes till 3 p.m.
Okay.
If it says didn't give sign out, no because after 3 p.m. or no couldn't get a call. Yeah, and again, it's not reviews. It's just for your none of Tony won't see any of this. It just goes straight to you, and it's just for you. And it's just 3 p.m. And if you have any issues, let us know. But encourage the PACU nurses to call you first and ask them to call you at the end of the PACU stay. If you are going to be late that day, you can say, you can call me after 3 p.m. I'm here till 7. Feel free to call me. But really encourage them to call you for anything and call you at the end of the PACU stay because you want to know how your patient did.
You might want to do a quality check on how the nurses are filling these out because I dropped my patient off and the nurse filled it out immediately. And assumed nothing was going to be wrong.
Nothing was going to be wrong.
Me.
Okay. I'll let them know. They're going to hopefully get CE credits. They have to get education credits throughout the year. So since they're sort of educating you guys on their PACU patients, they're going to hopefully get some education credits for this, so they're incentivized for it, which is a good process, but
I think one thing that I've talked to some people about, which would be a good way to continue this, I think long term, and verify that it's actually good data, is to call your attending at some point after you get your next case started and say, hey, can you come in for me for 10 minutes while I go see our last patient? I encourage the people I work with to do that with me so that they can go see the patient and pack you after they're more alert, more awake, and they can really get a sense of how things are going.
yeah, I'll remind them. It shouldn't be filled out right away.
Yeah.
That defeats the purpose.
They were like, no nausea? Okay. Did I call you? Yes. And they're like saying it out loud as they're doing it, so this is very...
Was that Tom?
I...
Sounds like something Tom. Sounds like something Tom would do for sure.
I'm neither confirming
Yours
or
was Tom? I
denying.
can neither confirm Tom.
I love Tom. Don't tell him anything.
All right. Can neither confirm nor deny.
Dr. Oliva, when do the ITU results?
Way too long, unfortunately.
Yeah,
It's usually
months.
the first or
You'll-
second week in April.
You'll have long forgotten about it.
Yeah.
The trauma will be over and then just rip it.
No one expects you to do good on it. Like, you specifically.